2024-25 here at Darchei Noam, Dr. Gary Bloch. So it is my pleasure to read just a fragment of Dr. Bloch's accomplishments. And Gary Bloch is a family physician in Toronto with St. Michael's Hospital and Inner City Health Associates, and an associate professor at the University of Toronto. Doctor's clinical education, program development, research, and advocacy interests focus on the intersection of social risks to health and frontline healthcare. He has led the development of internationally recognized clinical tools, innovative health team programs, and educational curriculum. Dr. Bloch is a founder of Inner City Health Associates, the largest provider of health services to people experiencing homelessness in Canada, and the advocacy group Health Providers Against Poverty. He has advised the Government of Ontario on poverty reduction, collaborates with numerous NGOs and community groups, and works toward social change to reduce the impact of social marginalization on health. Dr. Bloch, I can probably take 20 more minutes to recite your publications and your accomplishments, but there is nothing like a word of a scholar. May we sit at your feet and drink your words with thirst. Welcome, and we're eager to learn from you.
Thank you so much, Rabbi. So, what a pleasure to be here again. All right. I just want to say before I begin a huge thank you to Rabbis Ryan Leshner and Rabbi Aaron Rottenberg, who really helped me engage with what is a fascinating parsha, a fascinating part of the Torah, as I think you will see. And, you know, help me kind of find a journey through it. And I will tell you there are many journeys through this parsha, and I encourage you to have conversations with those far more learned than I on the sort of the Jewish and rabbinical side of this. For years, I resisted a powerful lesson of social justice work. We should not strive to gain power. We should strive to give it up. And this morning, I'm going to focus on what that means. So let me start with a story. I met Alan about 12 years ago in my clinic in a homeless shelter. He was in his mid-50s. He'd recently moved into the shelter from an encampment in the woods. He'd showered and shaved, but he still looked pretty disheveled. He was thin and wiry with a purposeful stride. He greeted me briefly, but didn't smile. His case manager told me he'd been complaining of chest pain and had a history of heart attacks. Alan confirmed this in a few words and made it clear that this had been going on for years. I tried to dig deeper, but was met with a quick shot of anger. I tried again and was assaulted with a sexist comment, then a racist diatribe. 5 years later, Alan sees me regularly in my family practice clinic. He bounds in with a present he bought for me on a camping trip out west. He is housed, he has a great job, driving for a construction company. He has a girlfriend who stays with him more days than not. He's taking his medications, and the chest pain is a distant memory. Alan's story came to me as I read this week's Parsha, Tazria-Metzora. At first glance, this Parsha is a doctor's dream. It offers in fascinating, some would say gross detail, the diagnosis and management of a mysterious skin condition called sa'arat, which is often translated as leprosy, but isn't really that. The healer here is the priest, who is tasked with assessing the character of the rash and is guided through a diagnostic process. The details are vivid, of discoloration, hair changes, swelling or depression of the skin, a smooth or scaly surface, and spread of the rash to all or part of the body. If the diagnostic criteria are met, the subject is banished from the community until it resolves. The person's clothes might be washed or burned, their house might be cleaned or destroyed. Luckily, there's also a process of reintegration involving some animal sacrifices and another detailed exam. If the priest determines the rash has resolved, the individual is carefully brought back to the community. To add to the medical fund, there's more, including designations of impurity for women after childbirth and for menstruation and male genital discharge. I imagine centuries of yeshiva kids having a field day. I mean, honestly, if I were your health scholar in residence, I would have spent a glorious 20 minutes dissecting the clinical accuracy of this parsha. But that's not why we're here. And honestly, some things about this parsha really bother me. It offers an approach to healthcare heavily reflected in the Western medical model that I've been struggling to change throughout my career. Priests are instructed to look at illness through the gaze only of the diagnostician. They diagnose based on superficial observation, visible afflictions of a person's outer envelope. We see disease and we treat. There are no stories of the afflicted, there's no context, no sense of the individuals, families, communities affected. There's no sense of the backstory or of the impact of these illnesses. There's no recognition of the centrality of people and their stories to healthcare. This is all about the health provider, the hero, the priest as Dr. House. As we discuss the social implications of this approach to illness, Rabbi Aaron Rottenberg, who, by the way, is here today, which is an honor, highlighted for me an interesting element of this condition. It seems to start not only in people, but sometimes in their clothes or houses. I actually got shivers as I recalled a powerful poem by Bertolt Brecht called A Worker's Speech to a Doctor that explicitly links social context to health. He wrote, "We know what makes us ill. When we're ill, word says, you're the one to make us well. For 10 years, so we hear, you learned how to heal in elegant schools built at the people's expense, and to get your knowledge dispensed a fortune. That means you can make us well. Can you make us well? When we visit you, our clothes are ripped and torn, and you listen all over our naked body. As to the cause of our illness, a glance at our rags would be more revealing. One and the same cause wears out our bodies and our clothes. The pain in our shoulder comes, you say, from the damp. And this is also the cause of the patch on the apartment wall. So tell us then, where does the damp come from? Where does the damp come from? I could have easily diagnosed Alan with heart disease, told him he had high cholesterol and high blood pressure, sent him for a cardiac stent, put him on the standard medication cocktail, and told him to exercise and eat better. He may have emerged free of chest pain, and I could have stepped away knowing I'd stayed true to evidence-driven medical guidelines. That would have been seen as adequate doctoring, and I may have been happy to be done with him and his anger. but he wouldn't have been cured of much at all. I needed to look beyond his chest pain, so we sat down again. He told me of a hard childhood, abuse by family members, dropping out before high school, a series of hard labor jobs, and of the depression that crippled him and left him homeless in his 20s. He retreated to the woods, living in ravines and forests alone for almost 30 years. He had 2 heart attacks in that time. Once he crawled out of the trees by a highway to seek help, but no one would pick up the homeless man, so he had to stumble 5 kilometers through his chest pain to a hospital. He was literally pushed to the margins of society. I saw where his damp came from. His anger gained legitimacy as he spoke. And then, amazingly, it started to melt away. He felt seen, connected, human, and he transformed. Over the next year or so, he got rid of his tent, settled into an apartment, got a job, and found a partner. Sounds too easy? The story's true, but I agree. In my November Dvar Torah, I spoke of the hard work of social justice. I said if it feels easy, we're probably not doing enough. And I stand by that. Like with Alan, engaging with stories opens a window onto the causes of illness, physical, psychological, and social. And this may offer a degree of healing. It's more than a Band-Aid, but is it social justice? Hearing a story gives us insight into what's happened, but it doesn't prevent that story from replaying over and over. And the work of social justice, and as Rabbi Ryan reminded me of Tikkun Olam, is not just about witnessing the world's ills and not just about patching them up. It's about making tangible change. Last week, I was flipping through some old papers with my son, soon to be a counselor at Camp Shomria, and came across a resolution my partner Karen and I brought to the 7th Veda, the big decision-making meeting of the Habonim Dror North American Youth Movement in 1993. Karen's still here, by the way. At that time, barely out of high school and marching to revolution, we proposed the movement add a core pillar of feminism to its original 4 of socialism, Zionism, Judaism, and social justice. After a powerful and convincing introduction to our resolution, we wrote, "Therefore, we propose that the movement engage in a conscious struggle to eradicate sexual inequality within the consciousness of its members, as well as within the greater community." The meeting minutes note that someone tentatively suggested other social concerns like racism might also be worth some attention, but we remain steadfast in our allegiance to third-wave feminism, that sexism was the most basic of all inequalities, and the resolution passed. But what struck me as I read this with my son was that what we wrote feels so familiar. To eradicate inequality within the consciousness of its members as well as within the greater community. My analysis of inequalities may have become more nuanced over the years, but my core understanding of the solution has not changed. In Tazria-Metzora, I read no attempt to explore the contributions of power and privilege in the consciousness of healers and in society to the severity of the illnesses we witness, and no attempt to examine the ways in which that power and privilege guide our own actions in addressing those illnesses. The link between the diagnosis of tsarat, a declaration of impurity, and banishment feels so clear, so simple, so obvious. Through their adherence to the dictates of the Torah, the priests protected public health and protected their communities. What if, however, the cure protects us, but leaves those who live at lowest income, in the worst housing, those with the darkest skin, with the most precarious jobs, to suffer the worst effects of both the illness and the remedy? During the pandemic, this is exactly what we witnessed, and it led to an unprecedented mass reflection on inequity. I was involved in building systems to support people experiencing homelessness. Those of us with the power to make decisions were forced within weeks to admit that because we didn't fully understand the impacts on those we were trying to support, the solutions we were designing may have been making the situation worse. As we designed isolation, quarantine, and emergency care for people far from the center of power, we were forced to reach out to include new partners at our tables. These included community members, community leaders, and people working on the front lines in those communities. They told us how to meet their needs. Within weeks, and in partnership, we developed unique isolation facilities with innovations like harm reduction supports and safe drug supplies. We recruited a novel network of community members to reach out to low-income, racialized, precariously employed people, some of whom spoke only minimal English, but who were highly exposed to COVID and had little access to public health resources. The pandemic forced us as individuals and as institutions to confront the biases in our systems and in ourselves and their real impact on our society. And most important, it forced those with the most power to spread it out through new allocation of resources and through new partners in making decisions. The pandemic ripped the lid off social injustices the powerful had for years tried to hide. There's been a devastating movement to put the lid back on, though. In the last couple of years, a major backlash has emerged against efforts to address equity, diversity, and inclusion in our society. I get it. It's tempting to push back, to close our ears to others' stories, and to deny the power and privilege we have. But it is when stories of oppression implicate us, and when we are tempted to act to protect our privilege, that the work becomes most difficult and potentially most transformative. These temptations are rife in these difficult times, especially in our own community with its complex histories of engagement with oppression, where we are asked to ignore the impact of war on Palestinian civilians for fear of our own story being lost, and where we see charges of anti-Semitism used as cover for attempts to undo years of work to advance equity, diversity, and inclusion. We must continue to challenge ourselves, our colleagues, and our institutions to confront their power and privilege. In my workplace, we've been actively striving for over a decade to understand the impacts of racism and colonialism on ourselves as individuals and on the structures of our team. We listen to stories and histories, engage with and offer decision-making roles to people from communities affected, and participate in critical self-reflection that forces us to look at and understand our own privilege and how it plays out in our personal and work lives. And amid the turmoil, there are rays of hope. After years of creating intervention programs to address issues like poverty with dribbles of funding, we recently received a significant private grant to create a program to connect lonely, isolated, socially marginalized older adults to community supports and services. This program, what we call support, equity, engagement, and dignity for seniors, is explicitly led by and feeds resources back into the communities we serve. Our community health workers do deep relationship and story-focused work with individuals, and the program is structured around the devolution of power to communities through community development and empowerment work. Program staff are peers hired from the community. We have a community advisory council to which we're accountable. We participate in and are guided by community planning and leadership tables, and we do our best to ensure program funds flow to the community whenever possible. This is significant and even radical for a team like ours. We come from that Western medical model of control represented in Tazria-Metzora. But we are looking to be guided by those who have traditionally had no voice in our system. I describe this because it is the most recent stop on my social justice journey. I began by fighting for power and evolved to listening. Now, though, I am doing my best to support transferring real power over decision-making and resources to those most marginalized. If we stick with it, I think this approach could open the door to a radical ceding of power by those of us with the most systemic privilege. If we can do it within a structurally privileged institution like medicine, I believe it can be done almost anywhere. This devolution of power and privilege will be perceived as a threat by many, including many of us. But I hope we will stay focused on the critical, privileged, challenging path to social justice that will lead us to both a fairer and a healthier society. Thank you. Shabbat Shalom.